Welcome to the latest episode of MQ's podcast, Open Minds. So today we're delighted, Craig and I are delighted. We've got Josefien Breedvelt, and Josefien is a Prudence Trust Research Fellow at King's College London, I think at the Institute of Psychiatry, Psychology and Neuroscience. So welcome, Josefien. Thanks for joining us on our podcast today.
Thank you very much for having me. I'm really delighted to be here. Thank you.
Hi, welcome in.
Great. So we're just going to have a chat around stuff that you really interesting work you've been doing. And I think we'll probably focus on some of the young people's mental health stuff. But before we do, maybe we're always interested in taking us on a bit of a journey. And that journey is where you began. So you're Dutch, or you studied in the Netherlands, certainly. So you're going to tell us a bit about how you got interested in mental health. Because I know you did an undergraduate psychology degree, and I know you've done whatever, master's like in mental health science, and then a PhD as well. So just tell us a bit about your journey and what interested you initially on mental health.
Thank you. So I was first really interested in doing in doing medicine. So this was my original track, and then I had to take some exams, and then I realized actually I wanted to do. I kind of took psychology as a side university course, and I thought, well, I'm doing these exams to get into medical school, and I'll do psychology, and it just really captured me. So I just dropped my exams. I didn't look back, and I just went into mental health research, and have had kind of the fortune of having had so many different experiences as well. So I worked both after my master's, I worked in mental health charity. So I worked at the Mental Health Foundation, and alongside that, I did my PhD. And then I moved back to the Netherlands. So that was all in the UK. And then I moved back to the Netherlands, where I worked to help set up a center in complexity science and urban mental health. And after that, I moved back to the UK again to take up my Prudence Trust research fellowship. So I've moved around a bit, which you probably will have seen.
But your PhD was cross-national as well. You had Simon Gilbody from York was one of your supervisors, as well as Claudia Botting and in the Netherlands.
Yeah.
So how'd that work then? So because I'm just looking at the grand title of your PhD, towards a new model of depression prevention. So curious, so tell us a bit about that.
So it was actually because part of my PhD, I was working at the Mental Health Foundation, and I did my PhD part-time alongside my role. And it was mainly, I guess we were wanting to get it set up I wanted to kind of do my PhD in the Netherlands to keep the Dutch link, but then I wanted to really kind of have a UK connection as well. And so Simon was kind of agreed to be a co-supervisor. I think what's really interesting in terms of the kind of grand scheme is, that's hopefully what we'll go on to a bit more, is what I actually realized in terms of the evidence for relapse prevention, and then contrasting that to primary prevention of depression.
Yeah. And so in terms of the discipline, what the PhD then spanned, so a range of different disciplines. It was psychology, psychiatry, but broader than that.
And public health, public mental health. Yeah. So for example, one of the papers I worked on are what are the kind of public messages that you can include in public information campaigns. So, we say, exercise, or reach out to friends and feel connected to others, and focus on relationships. But what actually are the key messages that the public wants to include in kind of public mental health awareness campaigns? And there's quite a bit of debate about those as well, but at least we went to the public to ask what they wanted to see. So it even spans that as well.
And what were the key messages the public were keen to include in these campaigns?
We were thinking that maybe, trying to deal with your with thoughts and feelings and emotions. I guess coming from psychology, I think that would have come out as the strongest factor. But actually, the top one factor was avoid illicit drugs, and the second one was kind of avoid being in debt. So kind of debt advice. So much more of the kind of, I guess, social, environmental factors rather than individual personal factors came out as being the top preferences of the public that they wanted to see included in awareness and mental health information campaigns.
And then, so did you then translate that knowledge in terms into a campaign?
Yeah, so the nice thing was, in a way, that I was based at the Mental Health Foundation, and they were really keen on using research, so also other studies, and using that to inform their messaging. So this research then informed, for example, the how-to guides around mental health, the top 10 tips for mental health. Yeah. So all the kind of things you might have seen or heard of in the kind of coming out of the Mental Health Foundation. So I'm glad it had this kind of route into practice.
Yeah. And so did you say you were doing your PhD at the same time as working at the Mental Health Foundation? And were they funding the PhD, or was it just coincidentally that you were employed there?
I was employed there. They weren't funding it. I was able to kind of take a little bit of my time out of my job. And at that point, I was also the head of the research department. So kind of having a little bit of time. And I was really trying to merge the kind of my research as part of my PhD together with the research at the Mental Health Foundation, so that there would be a bit of synergy. Otherwise, I would be ending up having to do kind of two things at the same time. So that's how I got it set up, which worked really well in a way that also the studies that I set up some of them came from a need from the Mental Health Foundation. Okay, so what do we know, for example, about primary prevention for depression in young adults? Because the foundation was interested in developing a program around prevention of depression in young adults. So we went and did a systematic review, and then that then helped to kind of inform what we did and didn't do as well.
Yeah, what we didn't do is probably as interesting as what we do, of course. But just before we get more up to date, in terms of then you in the was it the University of Amsterdam, you set up the Center for Urban Mental Health. So tell us a bit about that. So did you say you established that?
So I didn't establish it. I was assistant director was my job title, and I worked with two co-directors, so two professors who obtained the funding, and I helped to kind of set up the center. So that included everything almost in terms of setting up the recruitment procedures, the website, all the coordination. So I have a lot of experience with with that and budgets. But what made it really exciting to me was actually that we were able that this was a center that combined the work from 3 different faculties. So it was the medical faculty, the psychology or social sciences faculty, and the physics, so natural sciences faculty. Yeah. And together we were trying to develop new solutions around or understand mental health from a kind of complexity science perspective. Yeah. So the content to me was really fascinating there as well.
And so then if somebody's to ask you what differentiates like a center for urban mental health from a standard center for mental health, what would you say, what are you doing differently? Was you mentioned the complexity science stuff there, but are you doing like the geospatial stuff, or is it much broader than that?
Yeah, I think the main focus was that we looked at urban factors. So looked at mental health problems in an urban context, but then also contrasting it to rural factors. So seeing whether, first of all, the first question is, are mental health problems increased in cities or not? And if so, which kind of elements of a city might associate with an increased risk of developing depression or anxiety or substance use? Those were the kind of conditions we were focusing on. So what are really and in a way that transfers across urban and rural, if you think about it, because you're trying to get to the optimal scenario where fewer people will have mental health problems. But it was mainly looking at kind of the factors such as kind of city size or population density or pollution and social connection and social conflict to better understand what kind of effects those factors might have on depression and anxiety. And you might have those, I guess you could say, in a rural environment, you will have different challenges, such as access to mental health services and support. And then
has the centre then worked with policymakers and to try and obviously, because these are obviously macro level factors. So if he's had much fortune in trying to get that evidence into practice or into policy.
Well, the point that the center is at, in a way, is that we have like this really strong connections with urban initiatives, like for example, London Thrive, New York Thrive. Those are kind of city level initiatives around mental health. But I think we're still at the point of kind of trying to capture it and capture the complexity and then move towards really tangible recommendations, because what really kind of struck me also from working in the Mental Health Foundation is that you can have the evidence, but then actually translating that to something that a policymaker can use is a whole separate kind of question. And what is useful information, and how do you translate that? So I felt that we were maybe more at the point of trying to understand and map, and then move towards kind of in the next phase, which the center is currently at, move towards solutions and tangible approaches.
Okay, great. Okay, so fascinating work. So if we fast forward then to your Prudence Trust Fellowship, so is that focusing on youth mental health now, is it?
Yes.
So tell us a bit about that.
So in my fellowship, I focus on, ambitiously, I'm trying to understand what works for which young person, age 5 to 25, for preventing the onset of depression and anxiety. So I'm really, really interested in trying to better understand what approaches really work and which don't work. You will probably have seen the recent trial on mindfulness, the Myriad study, finding null effects and finding a moderator effect of people with high baseline symptoms of depression having higher symptoms afterwards. So the intervention might be perceived as harmful.
So
I'm actually, my job is now to kind of tease that out, but then looking at the whole literature of all the studies that have been done. And I'm also looking at trying to find kind of groups at risk of developing depression and anxiety. And finally, also translating all of this knowledge, and how do we best translate some of this understanding to practice, to make sure that, for example, a charity or a local authority would actually know what to do. And I think that's a big question at the moment. What do we do around prevention?
I mean, that's an incredible, I mean, that is, when you said at the outset it was ambitious. It isn't half ambitious. Wow. So how long is the fellowship for?
It's 3 years.
3 years. I mean, and so how far into it are you?
I'm into it 1 year.
1 year.
And it is ambitious, but in a good way, in that I have some experience with the methods that we're using. So one of the approaches we're using is individual participant data meta-analysis, where you bring together all the trial data from randomized controlled trials, put them into one big database, understand what works for whom. And I have done that before for relapse prevention. So in a way, I've learned from my mistakes of the past, and now hopefully this will go quicker. And so far it's going well. So we're on track.
Excellent. So well, maybe we'll come back to that. But just I was going to mention the relapse prevention individual level data meta-analysis, which whatever in Nature Mental Health this year. So what was your key findings in that? Because that's obviously a fascinating and really important, obviously, topic area.
Yes. So we set out there to understand what interventions, psychological intervention, work for which individual for preventing depressive relapse. So that psychological interventions added to treatment as usual compared to treatment as usual or other controls. And we found, I think the main effect we found was that it seems that psychological interventions work best for those who need it most. So those with 3 or more prior episodes of depression before they receive the intervention. That's a kind of the result. And alongside that, which is already what we kind of know from previous meta-analysis, also those that I've worked on, is that psychological interventions in general, adding them to treatment as usual, reduces the risk of relapse. So it's a good, I guess, a recommendation is to add it, especially for those who need it the most.
I mean, so that is obviously a positive message. In terms of then, you're just saying the lessons learned. I'm involved in an individual participant data meta-analysis for youth self-harm. So I'm not leading it. I'm just one of the people contributing data. but it is one heck of an undertaking. So what lessons learned have you got, or what from having done it yourself?
Yes, you're right. It's a lot of work. And I think when I started, I started as being, I thought, oh, I'll do this. This was 2017 for relapse prevention. This will be fine. I'll just do this in 2 years, and it's part of my, and it will be really interesting. Of course, it's really important. Lessons learned is I think one of the challenges is to keep track of all the work. So one of the things we kind of have is a system of who we've contacted at what time point, and making sure we get back to people within a reasonable time frame. And I now have people that can help me. So I've got a small team, and back then I did it mainly by myself. So having help and being able to delegate is definitely a lesson learned. I don't know about the project you're working on, but I hope that there's a team of people who are leading it.
I think a small team, I think, same idea.
Yeah.
But the thing I was just been curious about and I suppose when thinking about it is that obviously when we pull together the different data sets, I wonder, and I suppose it's interested in your view, is methodologically or statistically, what is there a challenge of the fact that you're often, depending on how you do the analysis, of course, and how you combine the data, but are you artificially inflating power? But and which doesn't necessarily take into consideration heterogeneity, I wonder.
Yes, so this is really crucial because the studies we're including, they have to be as similar as we can get them to be, because otherwise you're putting apples and pears and everything together in one data set, and what are you really analyzing in that case? So for this study and also the previous IPD, we had to be really strict. Okay, this is the type of so we're really interested in primary prevention in this. So participants can't have previous depressive or previous history of depression, can't have high baseline symptoms. So that's really crucial to keep everything that you're including very clean. And you'll have to exclude lots of studies, even though they might be interesting and relevant. And you think, but you have to be really strict on that. And then also one of the issues we also had in a way with the Nature paper is that even though you have a finding, we do caveat it there in terms of the sample size. Is it big enough to actually make an inference for those with 2 or fewer episodes? So that was a bit more than 270, if I'm correct, compared to the overall sample size. The question is, did we have enough power? And we hope to collaborate more with also statisticians to actually work that out, that issue of power. So it's a really good point.
But I think the other one for me is thinking about, so in your study it's the same, you've gone for psychological treatments and they've all been considered as broadly speaking the same, and it's the same in ours. We've combined different brief interventions we're looking at. But again, it comes down to that it is a challenge. I mean, I can see that. I mean, I'm hugely in favor of it, especially in a field where you have, relatively speaking, small numbers of trials, and you're trying to maximize our understanding, and especially in a tailored way of So in our case, what I was looking.
Yeah, so that's I think one of the really important things, maybe if not one of the most important things to look at, is what studies do you include, and also what outcome measures do you include, and are they comparable? So we only include clinical diagnostic interview, both for the relapse prevention and the onset prevention studies, because we know I think that's kind of our determinant of onset. And in a way, you have fewer measures in that case. So for relapse prevention, it's mainly the SCID, but that is a criteria. Then also looking at the interventions, not including, kind of trying to be clear on you're interested in psychological interventions for relapse prevention. What is your definition of that? So being clear from the outset is really, really important. And then also the participants you're including, trying to make sure that they're similar as well, or as similar as possible.
Yeah, absolutely. No, I think, and the other bit I really like about it is you can then look at moderation or moderators more easily, I would think, because with your obviously increased sample size. So ours is still in the midst of it. So okay, so that was really interesting. So returning then, Josefien, to your fellowship then. So you said the first bit is trying to tease out which interventions are effective. And so is that are you going to do an IPD there as well? Is it the same plan?
Yeah, exactly. So also which interventions are effective and which aren't, because overall what we find is that interventions, I did a previous meta-analysis and I actually found that I'm also really interested in kind of the long-term effects of these types of interventions. So not only kind of do they work and for who do they work, but also for who do they not work? Are there potential groups, like for example, in the Myriad trial, are there groups who actually respond worse? Because in a study, you're reporting on your kind of overall effect of the intervention. So that's what I'm really, really interested in figuring out. And then also looking at the long-term effects, because I think in primary prevention, I haven't seen it that much, those really long-term effects, partially because they've not been studied that often, compared to relapse prevention, where you have kind of 2-3 year follow-ups. So this would be really interesting also to see maybe there is an approach that can really give us long-term effects, if we can, of course, have the measurement for that, the long-term outcome measurement.
How long-term is long-term, you thinking?
I'm thinking, this is really what I'm really, really keen on studying further, and also hoping that future studies, of course, it's very difficult to include it, but I'm really thinking 10 years long-term. But the caveat is the studies that we are including, they may have up to 1 year, maybe 18 months. I think 18 months is the max from what I've seen. So we're kind of in the situation where here's hoping for future studies where you can actually think, okay, in 10 years time, this is what this thing has done, or this intervention, but we're not there yet.
I think the 10-year one, I was think that's incredibly ambitious, because is it reasonable to expect, say, a 10-week, 12-week, 6-week intervention to have an effect 10 years later? Yeah,
well, in relapse prevention, we have seen that is the case. So there are studies, for example, preventative cognitive therapy, where they have found that at 10 years and then at 15 years, there is a reduction in relapse risk, even after such a long time. So maybe it's different for primary prevention. Could be.
Yeah, we'll see. Yeah.
Maybe we can find that, and that would, of course, for me, would be quite the aim to achieve.
Well, I wish you the best of luck with that. And so we're a third the way through.
Yeah.
So the other question we often ask our guests is, so separate from what you're doing now, but what do you see as like the number one priority for mental health research? And in this context, let's focus on young people maybe. What would you, if you had all the money in the world type thing, what would you invest in and why?
Well, first of all, more money, because I actually recently read a report, I think it was from MQ, that 3.9% of research funding goes to prevention. So, and of course I would focus on prevention because, that's my area of interest. So if I had all the money and all the funds in the world, I would really try to understand how do kind of individuals respond to preventative interventions, and how do they work? Can we better understand, okay, we offer someone an intervention or an approach, but what actually makes it effective for this person? What are the processes that change during these interventions? And then a bit more of a more lofty aim is then to have sustainable effects. So to understand how we can get these approaches to kind of last longer, and also sustainable implementation. So how can we actually get some of the approaches that may work or don't work, which we will hopefully find out that kind of personalization earlier, but how can we get these approaches implemented? Because I'm surprised that sometimes when I speak to colleagues, they kind of, there's still some hesitancy around where do we actually deliver preventative interventions, and what is the most optimal framework for doing that. So I'd be really interested in finding a solution for that.
And what's your, so thinking about settings then, so what's your hunch though, an informed hunch, where would you think, sir, where would we get our best bang for a buck? Which setting would be most optimal?
Yeah, I think so. One setting is online, but I think from what from my conversations, I think schools is probably a good place to get prevention. But the challenge is kind of when you go 18 to 25, the young adult group, where do you go there? So it has to be a multitude of ways. So schools, maybe for children who are in schools up until that age, and then for young adults, we can think of universities, but also online, workplaces. So I don't have like the one, and I think that's also the challenge with prevention. It's kind of in many settings in a way.
But if you think about the literature, the mental health literature, and I'm thinking about it from the sort of suicide, self-harm side where we work in, and we know lots about mental health up to your teens and 18s, like up to 18, say. And then there's this big gap, actually. There's this huge gap in our knowledge and understanding, really in-depth work on that 18 to 25, 18 to 30. And actually, a few years ago, we did a national survey in Scotland, and it was the first of its kind ever. And I don't think a similar study has ever been conducted in England, even, trying to map the mental health of young adults. Now, there's, as we know, then in the UK, in England and Wales, you've got the adult psychiatric morbidity survey, whatever, every 7-8 years, whatever it is. But that's not large enough for you to get a fine-grained understanding of young people because it's across the lifespan. So I agree. It's a huge gap actually in our knowledge and understanding. And then I suppose in a related sort of question, thinking about somebody who isn't necessarily in research, but say there's someone who's interested in mental health, and obviously mental health is everywhere. We see it a lot now, which is good news in terms of campaigns and so on. But there's an argument I maybe have the campaigns, the public awareness campaigns. There's a challenge with those because perhaps we've raised so much awareness, but now there's not the services or support out there to meet that need. But I suppose that was just a sort of a meander. But I want to get back to the question for you, which is, so what are you, in terms of the common misconceptions, like what do you think of the common misconceptions of people who are not necessarily in research around mental health, especially youth mental health?
So for me, not necessarily in mental health, is what I see is that, with the increased levels of, or reported increased levels of mental health, there is kind of this need to act, to do something. We want to be implementing new approaches, new interventions. We want to be addressing, we want to do mindfulness in schools. I think that kind of assumes that we already know that works and that we know that is the way to go. And what I would almost want to do is kind of take a step back and think, do we know that works? Can we be more fine-grained in finding out what works for whom? So maybe to take a step and a pause. That's my initial reaction when I see, calls for interventions or implementation in schools around mindfulness. I think maybe we should take a pause.
We have to take a pause. And I know obviously there's been a lot of coverage in the British media recently for well-meaning calls for mindfulness to be universally administered in schools. And what the Myriad trial shows very clearly, as you've highlighted already, is that is not helpful. And we need to understand that better. So I think that idea of a pause, I think, is really, really welcome. But I think that, but then the other bit is, would we ever expect a universal intervention? Would we expect it to be effective universally in any other setting? So why would you expect it to be effective in a school setting? And I think we also the extra vulnerabilities and concerns in delivering in schools. And actually, you may have seen Lucy Folks's piece, her most recent piece, also in Nature Mental Health, actually last week, I think it was, in which she's calling for work in schools that we do embed evaluation, including adverse outcomes, a range of other recommendations she's got. And it's a really useful piece.
Yeah. I agree. No, I agree. I think we need to take a pause and think about measuring adverse outcomes, identifying the groups that may have higher symptoms at the end. Like, that's really worrying when you see that, and then you think you see the contrast with what is happening in practice as well. So I think, yeah, I fully agree on that.
And then, so just going back into your fellowship, the third bit of your fellowship, is that the implementation phase? Is it?
Yeah. So the second bit is the kind of identifying groups at risk. So trying to understand, maybe not only look at risk factors, because often when we try and understand, when we look at risk, we look at kind of risk factors. But so that's the kind of the second part. And then the final part is implementation. Mm-hmm. So how do we actually translate some of the findings to practice, but also what are the barriers and facilitators to implementation? With prevention, it's, as we were already discussing, it's quite a tapestry. It's quite a landscape. So it's trying to kind of speak to all those settings and try and find out what is helpful where. And that's what we're doing in co-production with charities and policymakers, and also CAMS clinicians and primary care practitioners to really bring them all to also local authority, public health leads. So try and bring everyone together and see, what do you think your role is in this, and how do we come to a solution, or at least how do we find opportunities to deliver maybe more sustainable preventative approaches that work. that is the baseline.
but make sure you stay in touch with MQ, because that's obviously one of our missions, is really looking at that implementation phase, and we do a lot of work in that space, and we've written quite a bit recently on what we see as the priorities for preventing mortality premature mortality associated with mental illness and distress. But a lot of it is looking at that implementation phase, and as you'll well know anyway, that MQ is a really good network in terms of all the different charities and other organizations involved. So please, I would really encourage you, if it's helpful, get in touch with MQ in terms of who might be able to support some of that work when you get to that stage. Josefien.
Thank you.
So just sort of trying to bring it all to an end. We end with just one sort of unrelated question, which is, it will be a surprise to you because you don't know what it is. But there's one completely different question. But before we sort of finish the substantive bit, then, so the co-production stuff you're doing, then that's feeding, and that's obviously this third phase.
Yeah.
We sort of skipped over the second phase, just so you get some clarification. The second phase. So the second phase, then, you're looking at risk groups, and is that just looking to see, is that secondary data analysis of the existing literature, or
So it's analysis of longitudinal cohort studies, so ALSPAC and ERISC, and trying to. So often when we think about risk factors or look at risk, it's kind of looking at one factor and what does it do to the kind of onset of X, Y, or of depression or anxiety. Yeah. But what I want to do is kind of bring together, look at clusters of risk factors. So look at, for example, child experiencing childhood harm, familial mental health problems, and see how, if you cluster those factors together, how big the group is. So the kind of how large the group is that is experiencing these factors. And what I'm trying to get to is to get the smallest group that is associated with the highest risk of developing depression or anxiety. So you kind of can think about more like targeted smaller risk groups, rather than at the moment, in terms of prevention, what's often being done is we look at people with high depressive symptoms. So that's our risk group. That's who we should maybe be focusing on. But can we not cluster that? Can we not look at finding really, really targeted groups that may benefit the most from a preventative intervention?
And so how's that? So that's secondary analysis from those existing data sets.
Yeah.
And so what fancy analysis will you be doing to do the clustering?
So I'm calling it clustering because it's it's kind of thinking about a way to communicate it. But what we're doing is we basically identify, first of all, one of the risk factors. So that could be female gender, and see how that kind of has the most optimal indicators for us. So that's kind of a small, kind of a group that we think is relatively small compared to the rest.
Mm-hmm.
And then also we look at the population attributable fraction and the number needed to treat. So we add some kind of cost effectiveness measures in there that tell you, okay, if we were able to target this risk factor, this is what it would do on the likelihood or the risk of developing this condition.
Yeah.
So we have one, and then we're adding other factors to that using regression. So it's a regression analysis. We're trying to find out which, if we add 2 or 3 factors to it, what will that do to the overall size of the group? And then also what will that do to the number needed to treat, population attributable fraction. So to basically, ultimately, you may be able to come to a small group that is associated with a higher risk. And we display that in a kind of in a dendrogram. So that's where the clustering comes from. So you can see what if I add one factor, what will that do to your exposure rate? What will that do to your attributable fraction, number needed to treat, incidence rate ratio? So what will it do to those factors? And then the more kind of risk factors you add, the smaller your group could be, and the higher the impact of intervening on that group could be as well.
And then obviously, so you then could tailor your interventions and accordingly.
Yeah, that's the idea. And maybe it will give you some more insight as well into what interventions might we need for this group as well. Maybe we don't have the specific interventions that target all these kind of risk factors.
And more than likely, we won't have those interventions.
Exactly.
They won't be sufficiently tailored. Well, the best of luck with that, Josefien. So before I do my very last question, and then thank you, was there anything else you were hoping to tell our listeners about today I haven't asked about?
I think the kind of take a stop and pause would be the main message around primary prevention of depression and anxiety, really to try and understand what we currently know works, what doesn't work, and then move from there.
That's wise advice indeed. Okay, so our last question, which is unrelated, which is we try and get people a bit of reflection, is, so what advice would you give your 16-year-old self?
To have a bit of faith and to worry less. You know, when you're 16, you think, oh, is it gonna be okay? You know, such a period of change, and you think, oh, will things work out? Will I get into this, or will I be able to do that? I think probably to just focus a bit. But it's hard as well. I know, thinking back on my 16-year-old, I kind of get that as well. But I think, to maybe, that's what I would say, to kind of keep that confidence.
I agree with that. I thought you were going to say pause.
Well, that's also a very good one, isn't it? To just pause and not rush.
And don't rush in, is that the lyric said. Okay, so Josefien, on behalf of Craig and I, huge thanks for joining us, and the very best with obviously the next 2 years in particular on your fellowship. And I'm really excited to see where that leads us as a field. So thank you very much.
Thank you so much, and thanks for having me.